Welcome to the Ramalinga Swamy Center Colloquium series on equity and social determinants on health. We are thrilled today to invite Murali Neelakantan and his colleague Ashish Kulkarni to speak to us today about universal healthcare and how it's just within reach with a little attempt and effort from our governments. They've been working on this issue now for several years now. They asked me to keep the introductions very brief because they would prefer their work to speak for itself. So I'm going to end the introduction here itself. This might be the shortest one I've ever done. I want to welcome all of our guests today. Please put your questions in the Q&A box at the bottom of your screen. We will pick them up for discussion at the end of this talk to the extent that it's possible. Once again, welcome to Murali and Ashish, and welcome to all of our attendees as well.
Thank you very much, Abha, for having us. As we've been working on this for a while, and I think the first and most important concept to be clear about is the difference between universal health care and universal health coverage. Very often, what you read in the press is almost misleading to the level of a crime because we hear a lot about universal health coverage. Now, the difference is just this, that in universal health care, I walk into a hospital or a service provider and I get health. I get cured, I get whatever healthcare services I need, I get the medicines I need. With universal health coverage, there's no guarantee that I will get healthcare. What I will get is some insurer saying that they will be willing to pay some part of it if I can get healthcare. So there are two different concepts. One is actually receiving the healthcare, and the other is an insurer paying for some part of that healthcare that I'm receiving. So it's very important to understand this difference. As I said, it's very easy to be confused, and a lot of what you read in the press, watching media, talks about universal health coverage. Now, does it really matter? Well, it does. And the reason it does is because there is free healthcare in India, but only for some, not for all. And so we have to ask ourselves the question, if some can have it, why not the rest of us? And that is really the theme of what we wanted to cover today. Now, I don't know how many of the people here read our paper last year, but if you did and found some concepts difficult, all I can say is that economists too are sometimes affected by this log kya kahenge problem, or in Ashish's case, what other economists kya kahenge problem. So Ashish insists that there is something called the law of one price. We've been debating it for many years. He insists that it's unimpeachable. And after many years of discussion, we came up with the idea that India really has many healthcare markets. And that might seem a little counterintuitive to all of you. And I've heard a lot of people come back to me and say, that can't be right. We have a national price for all drugs. Well, bear with us. I mean, Ashish has a story which begins with the most unimaginative line. 4 men walk into a hospital. Ashish?
Thanks, Murali. The law of one price, as Murali mentioned, is something that we've been debating for many, many years, and I doubt we'll ever find resolution. But based on the story that I'm about to tell you, you can decide for yourself about whether the law of one price is indeed applicable in an Indian context. And I wish there was a punchline to the joke that Murali started with about 4 men walking into a hospital, but unfortunately there isn't one. But let's listen to the story in any case. So imagine that there are you and 4 of your friends, and you walk into a hospital. Not only is there not a punchline, the story actually gets a little bit depressing because in our completely imaginary scenario, I'm going to ask all of you to imagine that all 5 people, the 4 friends that you have walked in to the hospital with, and you yourself are suffering from hepatitis C, which is about as unpleasant a disease as one can wish on anybody. I'm not wishing it, nor is Murli, on anybody. But imagine that the 5 of you are suffering from this particular disease. But it's not just the fact that the 5 of you are suffering from this disease. It also is the case that all 5 of you are eligible for treatment or not, depending upon where you work and what kind of work you do. So maybe the first of your 4 friends, imagine, is working with the central government in some capacity, and this person is therefore eligible for CGHS coverage. The second person, imagine, is working for, let's say, maybe for example, a cinema or a petrol pump, and is therefore eligible for ESIC coverage. A third person has purchased private health insurance. The fourth person is eligible for a particular kind of scheme, which I'll speak about in just a little while. And the fifth is you, who has no coverage whatsoever. Under such a scenario, if the doctor who's going to take a look at each one of you and figure out what the best course of treatment is for you, imagine that each of the five of you start to visit the doctor and come out after having consulted with the doctor. Now, the patient who is eligible for CGHS coverage will not only have free consultation, but will also have access to the medicine that is able to treat hepatitis C. And correct me if I'm wrong, Murali, but there is only one medicine that does the job as of now. It's called sofosbuvir. And this person who is eligible for CGHS treatment not only gets free consultation, but also gets the drug for free or nearly for free. It costs, if I'm quoting this from memory, but it costs about 900 rupees per pop under the CGHS coverage. Now, the person who is looking for treatment from ESIC, unfortunately, the hospital in which this little imaginary scenario is playing out is not covered under ESIC coverage. And so therefore, treatment is going to be a little bit expensive. Whether the drug is available or not under ESIC coverage is a little bit debatable, but under certain circumstances it is. So consultation fees are applicable, but sofosbuvir, unfortunately, in this specific instance, is not covered under ESIC. And so the person is going to have to pay not only for consultation, but also for ESIC. It gets worse because as far as we have been able to find out, we don't know what the price for sofosbuvir under ESIC is going to be. This information, to the best of our knowledge, is not publicly available. Now, the third person is eligible under the PMJAY scheme. But under the PMJAY scheme, even if you're eligible for PMJAY, consultation is not free and sofosbuvir has to be paid for. And finally, your fourth friend is the one who has private healthcare insurance. And under private healthcare insurance, OPD consultations are not reimbursed, so you're going to have to pay for it. And the medicine that you need, sofosbuvir, is not covered. And that leaves you, finally, the fifth person. You don't even have private health insurance, imagine. So not only are you going to have to pay for the consultation fee, but you also are going to have to pay for the sofosbuvir medicine. And out of curiosity, you decide to try and find out how much this medicine will cost if you were to walk into a private dispensary and ask for this particular medicine. And it turns out, actually, rather than tell you the price, if any of you feel like taking a guess in the chat section, given the fact that it costs 900 rupees under CGHS, and given the fact that Murali mentioned that the law of one price really ought to apply as far as we economists are concerned, then what do you think will be the price of sofosbuvir if you were to buy it from a private market? The chat section is open, so I'm quite curious to see what your guesses are going to be. The honor code applies, so I'm going to request you to not answer if you know the answer, but feel free to take a guess. All right, so we have one guess at 1500. Is at least 10 times, and that will make it 9,000 rupees. Couple of guesses at 2,000. All right, so the bad news is everybody got it wrong. So Praveer, congratulations for the highest amount mentioned, which is 1 lakh rupees per month. Actually, given the dosage, Praveer, you probably come closest. I'm not sure what the dosage per month is going to be, but each pill will cost in the private market 16,000 rupees. So not only is it 10 times as much, it in fact is close to being 20 times as much.
And we need 84 of those. The dose is 84.
And so not only is the law of one price not applicable, but there very definitely are different healthcare markets. Back to you, Murali.
So the point we're trying to make is of inequity. That those who can most afford it, the most privileged, are actually paying the lowest price for this. And those who can least afford it, those who are not covered by insurance, who are not covered by any of these schemes, are likely to pay the most for it. And so we have to ask ourselves that question, is this fair? Is it equitable? Ashish mentioned the CGHS, he mentioned the Employee State Insurance Corporation and those schemes. But there are others as well who are equally privileged as the CGHS, which is the armed forces, railways, and lots of state government employees, members of legislative assembly, all are eligible for these kind of a CGHS like schemes where they make a very small contribution, if at all, and they're entitled to lifetime of free healthcare. Now you'd think, well, that's part of your remuneration. What would it cost if we have to give this to everyone? Well, there are two numbers to remember here. That the cost of PMJ, which is available to those who can't afford healthcare, is 1,052 per annum. So if you were to go and buy insurance, and these are actual numbers the government's published, what it costs them, that you can, at 1,052 rupees per annum, you could buy a 5 lakh cover for your family, which is what the PMJ provides. But it does not, as Ashish says, cover OPD, and it doesn't cover a whole lot of medicines. It doesn't cover a whole lot of illnesses. So it's meant to be only for, as they say, catastrophic illnesses. Now, that's not a fair comment to make, because what is catastrophic for the person in PMJ? We already know that they are below the poverty line or close to the poverty line. Would 1,000 rupee expense push them below? Will 10,000 rupee healthcare expense push them below? It's not very clear what they mean by catastrophic. And therefore, there is a problem with definition of PMJ. So remember the number 1052 per annum for a very limited coverage. Now we have to ask ourselves, what is the cost the CGHS has for this overall best of everything coverage, which means that you can get the best care in the best hospitals anytime for yourself and your family. And that number is 4,583. So if you think about it, it's only about 400 rupees a month that the CGHS costs to provide per capita. And so you have to ask yourselves, what will it take to get from 1052 to 4583? And we'll come to this when we discuss our model. What else causes families to effectively be pushed into poverty as far as healthcare is concerned? Over the last many years, we've looked at data from the National Family Health Survey that shows us that there is a very high cost of healthcare, and the vast majority of the healthcare cost is paid out of pocket by Indians, which means that it is not covered by insurance, it is not covered by the healthcare schemes, it's not covered by government. We have some difficulty reconciling some numbers. The number we think we're comfortable with was 63% of all healthcare cost is borne out of pocket, which means that people are paying for this themselves. And again, that is really the problem we have to fix. That can we get certainty about the cost that people are going to have to bear for healthcare, rather than create this uncertainty about having to pay out every time. Now, one of the things the government has done to manage cost of these drugs is have Jan Aushadhi stores. And the claim there is that the cheapest medicines will be available at a standard quality at these stores. But what we found is that the Jan Aushadhi store doesn't necessarily have the cheapest drugs. So we've looked at some data across what it would, what it costs for the CGHS to dispense the drug, for state government health schemes to dispense the drug, for the ESI to procure the drug and pay it out. And we found that Jan Aushadhi is not the cheapest. So again, going back to the idea that economists tell us there is a law of one price, Janaushri should be the cheapest price. It's buying the most number of drugs. There is procurement at scale and distribution at scale, and therefore it should give us the best price. But again, here is the inequitable part that we found that those who are actually paying out of pocket, the cheapest option for them is the Jan Aushadhi store, and that is still not the cheapest in the market for drugs. The other issue we found is, and that's been, I think, well documented, is that even those who subscribe to the PMJ scheme and are eligible for the PMJ scheme, there are serious issues with the hospitals that are participating, exclusion of people, the quality of care, the extreme bureaucracy in many cases, a very arbitrary pricing of services, very poor tendering and procurement, and unavailability of drugs. We'll come to this issue of formulary in a bit. But all of these effectively push even those who are eligible for PMJ into the private market and having to pay out of pocket, and therefore pushes them into poverty. Every time we've tried to have a conversation around this, we're told that PMJ is fantastic, Jan Aushadhi is fantastic. Every year we get announcements that the government is capping the prices of drugs, and therefore it will be cheaper. We have cheapest drugs elsewhere, other than a few countries perhaps. We're the cheapest drugs in the world, and therefore, because it's affordable, it's accessible. Now, we have issues with all of this. We don't think that capping prices of drugs actually increases access. It makes it more affordable, but we don't think it increases access. We don't think that the way Jan Aushadhi is run actually provides good value for money. And one of the concepts that we write about in our paper last year was how do we deal with getting better value for what the government is doing in its own schemes. And Ashish will explain these 5 different schemes of the central government, and again explain to us why is it that they can't have the best price despite the central government buying tens of thousands of lakhs of medicines. Ashish?
But I wish I had an answer to the question of why we can't have one price. But for the moment, I'll establish the fact that there are different prices and what the world might look like if we try to have, if not exactly the same price, at least something approaching pool procurement. But to get to both of those, just give me a second. Let me share my screen. And what this shows you is there's a class of drugs known as the gliptins. Gliptins is a class of drugs which are used to treat high blood sugar in patients suffering from diabetes, whether type 1 or type 2. In this case, what we're looking at is 4 different drugs. They are respectively vildagliptin, saxagliptin, linagliptin, and teneligliptin. I'm not a doctor, so I'm not entirely sure of what the difference is specifically in the chemical composition of each of these, but they're all used to treat high blood sugar. But more than the chemical composition of the drugs, what is interesting is the next 3 columns. The reason we haven't included in this paper a discussion on CGHS prices is because those prices are no longer publicly available. They used to be about 3 years ago, but now sadly they are not. But of the schemes that we have discussed so far, we are able to take a look at the Jan Aushadhi column in the Jan Aushadhi prices, the first column. ESIC prices were available in the second column, and prices in the private retail market in the third column. I think in the case of private retail market, if you were to click on the link, you'll be taken to a website called 1mg.com. But of course, this goes without saying, you can take a look at any private medical suppliers' prices. And I hate reading out what is visible on the screen, so I'm not going to read out each of the numbers. But I would request all of you to take a look at the 4th row, the drug called teneligliptin. And the point that Murali was making is, if you walk into a Jan Aushadhi store, publicly available data tells you that one pill of teneligliptin will cost you 2 rupees if you were to purchase it from Jan Aushadhi, and less than half of that if you were to purchase it via ESIC. If you were to purchase it in the private market, of course, it will cost you much more. And if you're looking for headline numbers, or if you want to turn this into a clickbaity table, then take a look at the second row and the first column and the fourth, sorry, my fault, the second column and the fourth column. Saxagliptin is available for 4 times the price in the private retail market compared to what is available in Jan Aushadhi. But it's not just that, it also is the case that the price in the ESIC market is 1/3 that of the Jan Aushadhi market. So again, depending upon who you are and depending upon what kind of eligibility you're lucky to have as a consequence of your job or how much you earn, the price that you pay for the same medicine can be wildly different. It can be for the same medicine, 3 rupees or 9 rupees or 36 rupees. And this is one example. If you were to take a look at all the class of drugs, you get a very similar story playing out. So that's one of the points that I wanted to make. And the second point that I wanted to make is a point that we have made in our paper, but also has been made not just more eloquently, but also the numbers are attention grabbing. C.S. Pramesh and his co-authors wrote a paper recently in which they spoke about pool procurement, where the idea was to be able to figure out if we can get a reduction in the purchase price of medicines if hospitals were to quite literally pool all their purchasing ability together. In the language of economics, if they became monopsonists or solitary buyers. This is a point that we'll cover in more detail in just a little while. But before we do that, knowing Murali, I'm sure he'll have something to say about this table and about pool procurement. So Murali, I'll take it back to you and then come back and speak about pool procurement.
So what's interesting here is to look at these list of drugs. If you look at just these four, an area that we're researching, Ashish and I, with a few doctors, is on how do we decide what to procure. There are many models around the world. The one that we like is used in the UK for the National Health Service.
Nice.
And they look at new drugs and try and work out both on a scientific basis as well as an economic basis, whether there's any value to having this new drug on the public market. And because the NHS is free at the point at which we receive it, the healthcare we receive, they have a budget and they have to manage providing free healthcare to everyone within that budget. So if you look at these four drugs, the scientific basis for all of them to be on a public healthcare system is very, very low. There is really no need to have all these four on it, especially given the price. We know for a fact that some of these drugs or one of these drugs is sufficient and we don't need all four of them. For most patients, you'll be able to manage with Saxa. So again, an idea that we are trying to advocate for is a more rational use of these medicines. Now, we know from other research that when you have these many drugs and there's uncertainty of delivery and availability of these drugs, the patients will need to be swapped from one drug to another. Now, that causes a whole lot of issues for the patient, health issues for the patient. So consistency of drugs, especially of this kind, is really important. And when we have a large list of drugs and they're not available consistently over every day in the PHC or in the hospital, that causes health issues which are very difficult to reverse later. So one of the other ideas that we have is a rational formulary. Is shall we find, with some effort, 6 rather than 38 drugs for diabetes? And can we ensure these 6 drugs are available everywhere in the healthcare system? The result of that, if you just look at this list of 4, is that we will be able to save, just by rationalizing the list of drugs that we have, a significant amount of money in the nature of, Pramesh's numbers are 83% savings. We think we'll achieve something similar. We've taken a few in this area of diabetes, and we think we'll have a similar number there. So there are 2 ideas. One is, what do we do with pooled procurement? But the other is, can we rationalize what we are buying? So we buy fewer drugs, we can buy them more efficiently and make them available more widely. Ashish, back.
Yep. Thanks, Murali. So the other paper that we were speaking about is the paper that, as I mentioned, was published by C.S. Pramesh and his co-authors. I'll share this link also in the chat. Just give me a second.
And sorry, just to mention that this is actual data of actual
Oh.
savings, so it's not some theoretical economic model. What Pramesh and his co-authors are showing us is that they actually saved this much money, and this was only a small group of hospitals led by the Tata Medical Center. So it's not really, in that sense, having market power. It is just a group that decided to pool resources and buy together. So in a sense, they don't have very much leverage. They have some, but not a lot of leverage. So even in those circumstances, they've been able to demonstrate actual savings of about 83%.
Exactly. It's only going to get better from here on in. And as Murali mentioned, so this is based on the National Cancer Grid. So there's about 250 cancer centers in India. Again, perhaps you're able to read what is being shared on the screen, but the reason I want to speak about it is because I want to emphasize the numbers over here. The pool demand for 23 different centers and about 40 different drugs from these centers, they tried to figure out how much you could save if all of these hospitals were to get together and negotiate prices for these 40 drugs across these 23 centers. And it's been about, I think, close to 6 months or slightly more than that, that I've looked at these numbers and spoken about them. But every time I speak about them, I feel as if there must be something wrong. I don't mean that as criticism. I mean that as surprise and astonishment about how much savings can potentially be done. But if you take a look at the numbers, the procurement cost without negotiation for these drugs was 15.6 billion Indian rupees. That's billion with a B, B for Bombay. And it turns out this is based on maximum retail price. So if you don't do any negotiation, then it would have cost you 15.6 billion Indian rupees on an annualized basis. And from 15.6, given pool procurement, it results in savings of, and again, this number sounds unbelievable, 13.2 billion rupees. We don't come down from 15.6 to 13.2. We come down from 15.6 by 13.2. So you're resulting in savings of about 82% on the whole. That is, the median savings is 82%. The savings range from 23 to 99, but across all class of drugs, the savings is about 82%. And as Murali mentioned, this is for one class of drugs across a relatively small group of hospitals. If you really were to leverage the price of monopsony at a national level, the kind of savings you're talking about, well, your mind should be boggled. I'm sorry to sound so excited, but the numbers really are all that exciting, at least to me. Murali, back to you.
So if we can think about the government having the ability to negotiate with all the manufacturers and all the healthcare service providers a fair price, then clearly we should be able to provide a free healthcare service to people, and the cost of that can't be more than what the CGHS is paying. Now, if we then are able to look at CGHS, look at the other schemes and say, let's say we can even save 40%, half of what the Tata people could save. Now we're saying that the CGHS cost is 2,000 rupees. And if you were to take this to any poor person and say, for your family, will you be willing to pay 125 rupees or 120 rupees a month to get free healthcare? What do you think that person will do? What do you think the reaction of virtually every Indian will be if you're told for 120 rupees a month, you will be able to get free healthcare? So what we are asking for, or what we are thinking about, and what we are saying is that it's not really that far away. Even the poorest of the poor, except for those below the poverty line, just above the poverty line, should be able to, and we have some good examples of that. Ashish and I were to be in Varda, but flights got cancelled and we got stranded. But the Mahatma Gandhi Institute there has a subscription service where rural poor are willing to subscribe every month to get healthcare at a discounted price. Now, we think it's important for some to pay. Those who can must pay. And again, we're not talking about the rich. We're talking about the low middle class and the poor. When they pay what they can, they then have a right to good healthcare. Currently, the challenge we have is that it is seen as a benefit that is conferred by government on some people. So in a way, this whole relationship is of Maibab. By paying a small amount of money, the relationship becomes one of a customer who can demand a quality of service. And therefore, we think it's important for those who can pay to pay. Also, there's the problem is we don't have unlimited money. But if we have the poor entitled to the same benefits as the rich, and the only distinction is the amount of money we're paying. And again, it's not a new idea. Even within the CGHS, different classes of employees contribute different amounts to receive this benefit over their lifetime. So again, we're not saying this is a new idea that we've thought of. What we are saying is, can we have a CGHS level of service for everyone? And if you say, where is the money? We've just shown you that we can find you the money. Within the existing budget, we can find you the money. Within the existing PNJ budget, within the existing CGHS budget, we think we can save you the money. And if we can save you that money, we can include more people within it. The question is, what is then the space for private players? What is then the space for private health insurers? We're not the anti-rich. We're reasonable people. And in many cases, Ashish and I both qualify as rich. So we would like to have healthcare, which is maybe better than what the poor get. And that's perfectly acceptable. So it doesn't take away from, we're not nationalizing the healthcare system. All we're saying is government behaves like it does in a market. So in many ways, we're not asking for there to be a one system and everybody is involved in it. We're saying everybody should have access to one system, but it is a private market and government should behave as if it is playing in a market. Our criticism is that government is not behaving like a market player. It's in many ways not understanding that it can have a significant impact, but this seems very amateurish. So to the extent that the rich wanted to have special access, you want a room with a TV and you wanted air conditioning and you wanted a beautiful view of the garden, you're welcome to it. And there will be people who are willing to pay an additional amount of money, whether in terms of insurance or out of pocket, for that service. Why are we so concerned about this? And where did this all come from? It came from my reading my insurance policy for my car and at the same time having to buy health insurance. And it just occurred to me that I can get comprehensive insurance for my car, which means every dent, every scratch will get fixed. And I don't have to pay any more. Once I buy the insurance policy, it covers everything with no deductibles. But I can't do that for health. And it says something is very wrong when car insurance is comprehensive, but health insurance is not. I mean, there's something very wrong with us that we can buy this kind of an insurance and we can't do it for health. One of the questions we struggled with was, where is the supply for this? Yes, there is a demand for it, but where is the supply for it? We have two answers. One is that currently there is a market catering to this demand. So really, there are people supplying to this. What is missing is the ability of the poor person, the individuals, to negotiate a fair price. And that's where government setting a benchmark price will have an impact on the whole market. And Ashish will explain this in a bit. But once the government sets a price, then everybody else kind of clusters around that price. We've seen that in other commodities that very controversial, but once MSP is announced, then all the big traders are buying at about that price, not very far away from that price. When the government sets a price, you look at oil, there's not that much difference between petrol pumps. When one of the big guys sets a price, everybody else follows that price. You're not likely to see Shell having a different price from BP, having a different price from HP, having a different price from somebody else. So we see that once government sets a price, whether it is for hospital services or for drugs, then everybody kind of clusters around that price. Ashish, you want to explain that?
Perhaps an even better example from an economist perspective is exchange rates. If the RBI decides or the People's Bank of China decides that they are going to buy dollars at a particular rate, then that is the price that the market is going to be able to afford, in the sense that, hey, that is the best price that you can get. Private traders in China, for example, will always charge a higher price. You may as well buy from the central bank. In fact, that's how exchange rates are quote unquote set by any central bank that chooses to do so. So the point that Murali and I are trying to make is there are examples in the market, whether it is MSP in the case of agricultural commodities or whether it is exchange rates, governments can and do in fact try and at least set an indication of where they would like the price to be. Is it such an outlandish notion to try and do the same thing for medical goods and services both at the same time? And not only is it theoretically possible, there are in fact markets the world over where this has actually been done. A good example that may not perhaps be perfectly applicable, but certainly worth thinking about is, say, for example, right next door to us, in fact, where Thailand is concerned. So there are lots of markets where the government does try to set a price. In India, we are arguing not only is the government not setting a price, which is, well, we would argue bad enough, but it gets worse. It is setting different prices across different markets that it itself exclusively operates in. So not only is the solution as good as it could potentially be, not only is the government not optimizing, it in fact is trying to go in the other direction. And that makes it particularly painful that not only is one price not being established by the government when it has the scope and bandwidth to do so, but it is choosing to establish different prices. And that makes a market that really should be united and at as low a price as possible, unfortunately fragmented and at different prices, all of which are far too high for the poor to bear. Murali?
So if we can fix the way government procures, if we can then get a real one price in that market, then we think that the total cost of healthcare per capita will significantly reduce. If we can find that price, then we think it becomes affordable for everyone to be able to make a small subscription to get that. And once they pay that small subscription every month, then they should be able to get healthcare services for free at the point at which they receive it. Now, we've been asked some questions which I find problematic. One is, what if people consume more? Which happened, Ashish and I had a good laugh during the vaccine period when people were very worried. Nobody's going to take 2 vaccines. Nobody's going to take 6 vaccines. So frankly, healthcare is not something where just because I've paid for it, I'll have 2 of each. So the consumption is not going to increase dramatically. People are going to consume healthcare to the extent they need to consume healthcare services. They're not going to say, okay, I have a day off, let me go and spend it in a hospital. So that really, the argument that if things are free, more people will consume it, just doesn't hold good for healthcare. It might hold good for ice cream, it might hold good for many other things, but it just doesn't hold good for healthcare. It just means that people will get the kind of healthcare they need. Even when it is free, a lot of people, they choose not to go in for healthcare. So simple example, which we have again research on this, is that people think if I have to wait for 8 hours to get a vaccine, I'd pay 200 rupees and get it in the private market. And we saw this during COVID, that lots of people who we otherwise thought would not take the private vaccines actually did, because for them it would be a loss of a day's wages. And they would rather get in, get the vaccine, get out at 8 a.m. in the morning and get to work than wait in a government hospital and lose a day's pay. So we've seen people make these rational choices. And so we expect that people will be willing to pay a small amount of money. Most people will be willing to pay a small amount of money for this healthcare to be free, hassle-free when they go and receive it. And that will not push up the number of people suddenly, the demand will not go up dramatically because something is free. We've seen that in other markets. My favorite example is condoms. Condoms are free, but we haven't seen a dramatic rise in the use of it for decades now. So just because something is free in the healthcare market doesn't mean people will start using half a dozen of them when one will do. We haven't seen that. So that is one question we've been asked, and I'd like to answer it. The second is, how can we pay for everything? So one of the answers we have is that if we rationalize what we have available in the healthcare market for the public, and that should take care of most of our needs, then those who would like to have a slightly better drug, so in that list of gliptins, you want the latest, shiniest gliptin, then you're welcome to have it in the private market. Nothing stops you from going and buying a gliptin that is not available in the public market, because we're not nationalizing the business, remember? So the private market is continuing to exist. The one aspect where a slightly more nuanced answer needs to be said is on what happens to patented drugs. And it's an area we've grappled with for many years now, where there is no competition in the market. You put out a tender, there is only one person, which is the patent holder, who can bid for that tender. Then what happens? So we've looked at it, and in my past life, I used to be an IP lawyer, and I've looked at TRIPS quite carefully. And the answer is in TRIPS. And the answer is in many countries who have had to grapple with this. And the answer is simply this, that when the government needs to buy a patented drug, it puts out a tender like it does for any other drug. And the condition there is that anyone who can make the drug for that contract. So you will have the patent owner who will bid for that drug and others. India has a thriving generic market. So there will be many generic players who would be able to make that drug who would be bidding for it. Now, if the patent holder is the cheapest, may happen, is the cheapest, then they get the tender for the drug. Now, let's assume they are not the cheapest. Then what we do is look at everybody else and add a 3 to 5% royalty on top of the price, and then equalize and say, okay, now if we added 3% or 5%, and there's some discussion we can have around it, but it's no more than 5%. So if we were to add that number to the others who are not the patent holder, what would the price be? And as we've seen from the Sofosbuvir example, the difference between a patented price and the price of a generic could be in the order of 80%, 90%. And therefore, the government will be able to buy from a generic for the public healthcare system what is otherwise a patented drug. Now, this doesn't take away from the fact that the patent holder can sell the drug at this fantastic, whatever price it likes, in the private healthcare market. But in the public healthcare market, the price at which the government will procure this drug will be what is tendered, what is bid in the tender. Now, again, this is available. It's a TRIPS flexibility that was specifically negotiated. It is in the Doha Declaration. The law allows for it. It is there in the Patent Act, but we have never implemented it. So again, this is the way of the government using its monopsony power within the law to buy something at a price that it can negotiate against a monopoly. Otherwise, there is no negotiation. The third aspect of it, after rational formulary and the problem with patented drugs, is going back again to the law of one price, which is, what if we got rid of brand names for drugs? So let's say that the government buys drugs and they're sold in Jan Aushadhi and all these stores without specific brand names. They just sold by their chemical names. The cost of that drug, we expect, and I spent some time in the pharma industry, just by this one measure will come down by more than 30%, which is the sales and marketing cost on that drug. Suddenly you'll find that drugs are cheaper by 30% because you're not spending on the medical rep, you're not spending on advertising, you're not spending on branding, you're not spending on bribes to doctors, you're not spending on any of this. Suddenly you get a 30% saving just on this by saying we will not have brands. And again, it's not a dramatic idea. In most countries around the world, generic drugs are not branded, which means that a patented drug will have a name, but the generics will not have names of their own. And they'll all be known by their normal chemical name. So why in India do we have these brands? Why is it necessary? If we go to a market like this where the government is going to purchase, then it doesn't matter who manufactures it, it will have the same name. It will, of course, have the name of the manufacturer, but the drug itself will not have different names. Now, we have another paper out, perhaps going to be in print in a month or so, but where we deal with this issue of brand names. But these are the three things that we think will make it possible for everyone in this country to have what we think of as universal free healthcare. It is free in the sense that at the point of use of that healthcare system, we're not paying for it. It is not free in the sense that nobody's paying for it. People are actually subscribing to it. And therefore, as consumers, paying consumers of this service can demand the quality of service and demand healthcare. So that's our model. Ashish will add one last thing to it.
The one last thing, sorry, I missed the last bit.
Sorry, I said that the three things we've done is patented drugs so that everything is available for all. Brand names go away. There's a rational formulary. And once we're procuring for everyone, we establish a price. And the last thing really is what is the level of savings we're going to get to be able to afford to everyone, which means our model is everybody gets healthcare at the same level in the same hospitals. So your four men walk into a hospital, what will it look like now?
In an ideal world, it effectively will end up being CGHS for all. And the cost computations there are, as Murali mentioned, you're looking at roughly speaking 4,800 rupees, give or take, per person for 1.4 billion Indians. The truly ironical bit is the fact that if you take a look at our current healthcare expenditure, if you take a look at total healthcare expenditure for all Indians today, as per the government's own data published last year, we are looking at a number eerily close to 4,800 rupees. So the point that Murli and I are trying to make is, and the reason the talk has been titled what it is our per person expenditure, all accounts taken together, is already very close to what we think CGHS for all will cost. It just is a matter of, when I say just is a matter of, I'm underrating the public policy aspect of it, but it really just is a matter of getting our act together and figuring out how CGHS for all can become a reality. But the top line numbers tell you that it is very much in the realm of possibility. How to go about making it happen and how to take those first steps is the part that remains to be discussed. But is it a pipe dream? Both Murli and I are quite convinced about the fact that no, it isn't. Implementation is a challenge that remains.
So that was most of what we had to say. We expect there are lots of questions I see on the chat. So perhaps we can start with those, Ashish.
Yep, I'll read them out for everybody's benefit, and we can take them. Whichever one of us wants to take them, Murli, we can go ahead. So Pritam asks the first question: if government behaves like a private market, would this lead to exodus of good doctors and deprive people who still prefer public hospitals, not behaving as private markets? What are the unintended effects of the proposal that you are making?
Okay, so
I'll take
we've
my.
seen.
Yep.
Yeah, go for it, Ashish.
So,
So
I was just about to say, one part is that we simply will not know the unintended effects until we actually go ahead and implement it. That just is what Donald Rumsfeld very famously referred to as an unknown unknown. But that being said, at least I would argue, and I'm fairly sure Murli will agree with me, there is an experiment worth trying, if nowhere else, at a relatively small scale, learn from the mistakes, and then try and roll out at a bigger or a nationwide level. In fact, that in fact is how we have outlined the proposal towards the end of the paper that we published last year. That start with a couple of districts in a state, see how it works out, learn from the inevitable mistakes that will occur, and slowly but surely scale up. Sorry, Murli.
So the answer to this is we have a model of the NHS where you have very bright doctors within the National Health Service in the hospitals that are part of the National Health Service. But there are also a few which have practices on Harley Street, and nobody is against those doctors starting up their private practices on Harley Street, having babies of the Arab billionaires in the Portland Hospital or of Indian Bollywood stars in the Portland Hospital. Nobody's taking away any of that. And we're saying that so long as everybody has access to healthcare, we're not spiting those who have exclusive access, like I said, of a view of a garden or a TV screen or a meal, I don't know, by your favorite chef in the hospital. All of that is extra. And so doctors in the private healthcare sector will continue to have their practices, will continue to have a large number of Indians who want to have that special treatment. But at the same time, what we're looking for is not denying healthcare to anyone. So the problem we are trying to solve is not whether the rich will get great healthcare. The rich get outstanding healthcare in India, except during COVID. But in normal times, the rich get outstanding healthcare in India, better than most parts of the world. You get it quickly, you get a high standard of it, and at a relatively reasonable price compared to what our PPP is. We're solving a different problem here. We're saying, can we make sure that an acceptable level of quality is accessible to every Indian? That is the problem we're trying to solve. And doctors will be produced. We produce a large number of doctors. Once the government decides that it is going to procure all of these services, please understand that hospitals, including private hospitals, will find that this is a big enough market. Will find that there is a price which the government is offering. And if they don't take that price, there isn't a big market out there for the price they wish they could charge. So we're looking at it and saying, when the government decides that it will negotiate a price and will indicate a price to the market, we expect that the private market will respond to that price as well. We expect that more and more hospitals will be built because they know that they can get these patients who are willing to pay because they're part of the payment system from the government. So we're solving many problems here, but primarily it is what is it that will ensure that the poor and the lower middle class and the middle class can have access to healthcare. And we found these were the constraints. Whether doctors will want to be in public hospitals or not is not really an issue. If you go and look at all the public hospitals in India, you look at AIIMS, you look at PGI, Chipmar, all of the great hospitals in India, most of them are public hospitals. If you look at the great medical colleges in India, most of them are public. Very few private hospitals and very few private medical colleges have got this status as being the great medical healthcare facilities in India. There are very few of them, and even those few have had the benefit of government patronage. So, if you, I know some of you may jump up and say, oh, Manipal has a great hospital, KMC is a great hospital. They've all had government grants. The land was given to them free. They built a hospital on it with an understanding that they will provide public health care. So there are very few hospitals that are purely private funded that are doing outstanding work. And those doctors are very, very few. So there is no fear that any of the things that we are saying will drive doctors away from public hospitals into private hospitals. That market is very small. This market is very large. And this price will determine what that price is going to be.
Right. Pratik asks, what's stopping the government from doing pool procurement like the Tata Hospital did? Are they just unaware? Pratik, I'll give you the cynical economist answer and then we'll take the answer from the lawyer. More than being unaware, I would argue that inertia is at play. if it ain't broke, why fix it? So nobody's arguing that India's medical system works very well, but it isn't exactly failing either. So why try and do something when there isn't really an upside to doing experimentation? Is, I would argue, my best guess for why they're doing it. And like I said, that's a cynical economist's answer. Murli?
So we've spoken to a few people who had some influence with government in the past, and their explanation for it when Ashish and I were at a session in Bombay was that separate departments are separate empires in themselves, and each of them has a mandate, and each of them will go off and do its own thing according to its own rules, and they are not affected by any other system around it, unless there is some kind of clear articulation of pooled procurement from the top and an understanding of these savings, it is not going to happen. And this was in the context of why do we have, even when there is state procurement, each of them procures the whole supply chain separately. So it is not just that they're buying these drugs separately, it is that each of these drugs is supplied to a government warehouse and has a separate supply chain. Now, there's no reason why, when the drugs are procured, let's say they're procured separately, why they can't just be delivered directly to the hospital, the PHC, or the Jan Aushadhi store. So again, we are creating a parallel supply chain of government with its own warehouses, distributors, and all of that, adding to cost without actually achieving anything. So again, we see a great saving in rationalizing the supply chain when there is pooled procurement. So we just buy and it is delivered to the final place of consumption, which is what the retail market currently does. So again, there is a benefit to not having separate supply chains, one for ESIC, one for PMJ, one for Jan Aushadhi, one for the CGHS, one for the private market. Don't forget, these are all the same place. In the end, it is the same hospital, but they're getting 5 different sources of supply of the same medicine, which doesn't make any sense at all. So again, having pooled procurement means that we can also rationalize the supply chain. Again, we will get great savings from that.
Shelley asks, can this model work in an unregulated private healthcare economy? I would argue yes,
Yes,
I mean, in theory, yes, it very much can. Murli?
yes, and we're not regulating anything. So let's
Correct.
be very clear. What Ashish and I are suggesting is there is no regulation. It is just the government behaving like a market player. We're not regulating anything. We're not regulating price. We're not regulating supply. We're not regulating demand. Nothing. We're not regulating anything. The government is just behaving like a sensible, commonsensical approach to a market. I am buying these services. How can I get the best price and get the best service? That's all the government is doing. The government is not telling the market what to do. The government is not telling other players what to do. The government's only saying, this is how I am going to play. And it will play the game like any market player with other players in the market. That is all we're doing. So there is no regulation. As I said right at the beginning, we're not nationalizing the industry. We're not regulating anything. We're just saying that when government sends out price signals, sends out other signals on demand and supply, the market will react to it. So in that sense, we are free markets.
Yep. Just use the power that you have. So this is an example that I've quoted quite often. Shelley, I'll bring up the point again. If, say, for example, Shelley, you were to head operations for McDonald's in this country, would you want each separate McDonald's to go out and buy their own potatoes? Or would you want a centralized team to do procurement for all McDonald's across the country? What do you think will get you a better price? And if you end up saying it's better to have centralized procurement, we are saying, as with potatoes, so also with pharmaceutical products, centralized procurement is likely to lead to lower prices. That's our major contention. Preeti asks, how would we deal with the risk of moral hazard? I think Murli's already answered that question. At least we don't anticipate a significant rise in demand for medical services, given the fact that the price is significantly reduced. Hardly anybody is going to say, as Murli said, that, hey, I have a free day, let's go and spend it in the hospital. If anything, we do our best to avoid going to hospital. So sure, there may be some cases of moral hazard across a country as large as India, but both Murli and I don't expect this to be a significant problem. Prajakta asks, if you're proposing pooled procurement, will it be separate for states and union or one system, one nation kind of thing? Murali, do you want to take this?
So we think that once you get an indication of price, and if you follow this model that everything is going to be delivered at the place where it's going to be consumed, then frankly, once the price is indicated, all the state governments should adopt the same model. So in some states, for example, Tamil Nadu, there is a central procurement organization for all medical supplies. So in a sense, they've got the idea. But can they do it better? We think they can do it in 2 or 3 different ways. We think they can do better pricing, and they will get a better price if the central government indicates a better price. They will get a better price if they change the way they procure, which is the supply chain, which is they get it delivered at the very end. And that will do 2 things for them. One, they will get better price, but also they will get better quality. Currently, quality is an issue as well for us. So we think we can manage both with this one supply chain rather than these 6 different supply chains, one for the state and 4 or 5 for the different central schemes. So I think we'll make great value, and it will be a natural outcome of what we are suggesting. The central government leads, the states will follow. And some states will follow or perhaps do better than the central government, which is the WHO and lots of the NGOs and think tanks around the world hold up Tamil Nadu as the leading conceptual idea for healthcare procurement in this country. But we think there are a few tweaks we can add to it in terms of quality, price, and actual availability, which is the supply chain.
So I use the word advisedly, but the great Dilip D'Souza has a question. A health professional I spoke to about this commented, it might be the wrong prescription. Universal health coverage is not universal health care. Is this only about the insurance model, which has been a big failure in providing health care to people? Any thoughts in response? Murali, I'll let you take this one.
So Dilip, that's how I started this talk, by trying to explain that we can't be selling insurance. We are not insurance agents, and the government definitely should not be doing it. So our model is based on actual care, not coverage. And therefore, the title of this talk was very, very carefully articulated as universal free health care, not coverage. We already have coverage of all different kinds. And unfortunately, it just doesn't give us adequate coverage. I go back to this issue of why is it that my car insurance is comprehensive and my health insurance is not? And the problem with that is coverage. Coverage doesn't actually say anything. I have health cover doesn't mean anything, because does it cover 10% of your cost, 80% of your cost, 90% of your cost, 100% of your cost? What does it cover? So coverage is a very misleading term, we think, because it gives the impression that you're covered, when in fact, what you know from medical insurance is that you're not. So we find it very misleading, and therefore conceptually, we continue to use the term universal health care, not coverage.
So Dilip asked me a question. I'll respond to that, and then I think we have one last question. Great, simply because of the fact that I've been a fanboy of your columns for many, many years on Live Mint.
Yeah.
And I think I speak for both Murali and me.
Yes.
The last question for the day. Universal health coverage is a misnomer, Aruna asks, as universal model is missed at the core of things. Would you like to discuss this? So one quick response from me, and then I'll hand it over to Murali. Yes, I would argue that precisely is the problem. And as Murali mentioned, what we are trying to establish is a minimum standard of healthcare coverage for everybody in India. That does not mean that people who are able to afford better healthcare services, better in terms of quality, better in terms of whatever the perception is, should be able to get it. But at the same time, as a citizen of this country, you should be entitled to a certain minimum level of healthcare, no matter where you are in this country, no matter how much you are in this country, and no matter what kind of disease you have, catastrophic or otherwise. Establishing that floor is, we argue, necessary for our country. Above that, if you can afford a better service, of course, you should be entitled to it. Murali?
So the challenge with insurance is there's too much exclusion permitted. So every time you try to buy insurance, there'll be a whole lot of exclusions, which means that even though you've paid for it, you may not actually get the benefit of it. And we've seen that even where government provides insurance. So if you look at the PMJ scheme in India, too many people who deserve to be in it, need it, have been excluded. If you look at the United States, Obamacare, we have the same problem. Too many people who really need it have been excluded from it. So again, selling insurance hasn't solved the problem because it hasn't dealt with actual receipt of healthcare at the time of need. And therefore, again, we go back to this that every time we hear universal health coverage, we should jump back and say, no, 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 that's not what we want. What we want is universal health care. So we have to focus on health care, not coverage. And too much is written about coverage and how many people have been covered, how many cards have been given out. All of that actually doesn't translate into them actually getting healthcare. So we've got to be very careful when we read data that says 60 crore people have been given a card. Well, they've been given cards before, but that hasn't resulted in anything. They have a white card, a blue card, a green card, now a health card, lots of cards, but they haven't got any of those services. So we need to focus on the service, an insurance card or a PMJ card or a white card or a blue card. We need to be able to sift through this rhetoric that we are seeing in the press. We're seeing propaganda on coverage. So I think that's really important.
I'm going to add
Anyone
just one
else?
more question that was in the chat box, actually.
Go for it.
Yeah, this was wonderful. Prajakta asked, about essentially the lobbying power of the pharmaceutical companies, and what would their response to your proposal be?
Ashish predicts the market, so Ashish can.
Oh, no, no. I was about to say that you've been doing battles with the pharmaceutical companies for I don't know how many decades now, let alone years.
Yeah.
So please.
So I think we have to think of them as players in this market. India is a large enough market. The government is a large enough player. And therefore, if the government behaves in the way we're advocating, then the pharma companies will have no option but to fall in line. They cannot exclude themselves from that market. As I said, let's assume that all the patent holders decide we don't want to play in the government market. That's perfectly fine. We'll have the generics enter that market at a price that is negotiated with government, and it will have fantastic second order benefits. They will be able to manufacture the latest drugs with the latest technology today rather than 20 years later. So the spin-off benefits from our model is a great acceleration in the pharma space, in the healthcare space of science and technology. That translational work from what is on a patent on a sheet of paper, which is inaccessible to Indians, will suddenly become accessible to Indians. So the second order benefits of what we are suggesting is just absolutely fantastic. So you will have a divide where the Indian pharma in the generics business will love it because they think they can actually make a difference. They get a bigger share of the pie in terms of value and in terms of volume. It will have a reaction with the international guys where they'll probably take a view, and I've written about it, that not playing in the market and making the money in by way of royalties is not a bad deal at all. So they get royalties from the government market if they don't play in it, and they can price it at whatever price they like in the private market and make the money there. So it's a win-win really for everyone in this ecosystem. And if you think back on it, this was the deal we made when we entered the WTO with GATT. I mean, most of you may perhaps not even be born at that time. In the early 90s, this was the deal that the Global South made when it said, we will give you access to markets, but you must give us access to technology. That was the deal. 25 years later, we know that one side hasn't kept its word, and this is a way to actually force that bargain to play out. So I saw something from Dilip, but I couldn't read it.
We'll make the chat available to you later on.
Okay.
But this was wonderful. I mean, I think there's many more questions that keep coming up. I think just before we started this conversation, we were talking about this briefly, that this conversation was just about pharmaceuticals, just about drugs, and how even managing that element of our healthcare industry can lead to such cost savings. And there's many other pathways as well, right? And we didn't even sort of touch those. So the possibilities seem very endless and hopeful, I think, if we were to engage in these debates in each of these areas. This was, this turned out to be a pleasant surprise, right? We advertised just Murali and we got a 2-for-1 deal here. So thank you, Ashish, for joining us today and
My
for
pleasure
contributing
entirely.
so wonderfully to this conversation. It was great to have a lawyer and an economist in here, both of your perspectives, both cynical and optimistic based on the topic under discussion. We also, I think, have had the most active chat box here. Thank you so much for sharing articles and your work. I'm sure people have downloaded those papers and we'll be reading them later on as well. It was wonderful to have you here today, and I think I've spoken to Murali about this as well. I hope this is the first of more conversations. I feel like this could be a series of talks, and you've probably given them as a series of talks as well. Thank you to all of our attendees. I will note that usually we have a sharp drop off in the number of attendees after the talk is over, but everybody stuck around for the Q&A. So thank you to a wonderful group as well who is here today. Thanks again, Murali and Ashish. Absolute honor to have you here.